We are, Lisa and myself, going to be presenting on our integrated behavioral health hospital transitions pilot. And there are actually a number of people in the room who are working with us who are here. So Vanessa, Don, Jane, anyone else I'm missing, just stand up for a moment because you all could be up here presenting with us. And it just was, oh, and Donna Putnam from Dominican. And our from the county. Thank you so much all for being here. So we're going to whiz through our vision. So we have a lot of people working with us to make this pilot happen. And this pilot came out of a hospitalist meeting at Dignity Dominican Hospital. Let's see, I guess it was November, December of 2015. And Don, I remember vividly, you were across the room from me, and you were sharing this story about a patient who had had, the multi-million valve transplant surgery, and this person's underlying addiction issue was never addressed during the hospital stay, and the patient came back with the same problem after spending how much money and time and resources and heart of all of you working with this person's heart, and we really didn't do a good, we didn't really address the underlying issue. And Don said, we've got to do something, and I'm like, you're right, we got to do something. And so we started out, I think Vanessa was maybe at that meeting as well, and so we were born. And actually at the same time, it turned out that Donna Putnam, who does case management and wonderful work at Dignity, was working on a program for patients who were in the hospital who really no longer needed to be in the hospital because they were just getting IV antibiotics for their cellulitis or their heart valve issue. And so she was working on a leased bed program. And those two things were happening actually simultaneously. And then we converged to work together to try to figure out a way to address underlying behavioral health, substance use issues while in the hospital. So that was really our vision for what to do, so that we would actually be treating what was going on instead of band-aiding. So this is the flow that we've worked through. So hospital staff will identify patients with IV drug use, and for the purposes of the pilot, we work together with Beacon to have Beacon therapists come into the hospital with for patients who have Central California Alliance for Health and have this embedded benefit. So actually a big part of our initial process was figuring out how to get those therapists to be able to come into the hospital. That was not clear initially that we could actually do that. In fact, we got big no's initially. And so I have to say, there was incredible creativity and flexibility, both on the Alliance's part and on Beacon's part, and then a real, dedicated, collaborative eye on what our mission and our vision was together. So those first few months of working together, we were sort of like going up this steep hill that we didn't know that we'd actually get to the top. But we by using the Beacon and Central California Alliance for Health definition of being able to treat mild to moderate mental health as the primary diagnosis and substance use as the secondary, so basically that was the way we got in. And then once we identified those patients were greeted and met by the hospital staff and offered a referral for therapy services with Janus therapists. We obtained consent, and then there is now this process that is much improved between the hospital social workers and Janus therapists, and which is called Lighthouse Counseling, and then these patients are met in the hospital. or if they've already transferred to the skilled nursing facility, which is the leased bed program that I mentioned that Donna worked on, then they're met at the skilled nursing facility. In your packet, there's a description of that leased bed program that Donna worked out in conjunction with our program with Lighthouse Counseling, and we have some data. We're not going to go in depth into that work, but it's there for you, and Donna is here if you have questions about it.
Good morning. My name is Lisa Russell. I'm with Janice, and I'm going to share some of the quantitative metrics that we've been collecting through the project. Our measurement has been primarily focused on informing the model so that we can adapt it and modify it as we go forward and as we need to. And then Elise is going to share some of the great stories and more qualitative information. So here, for this period, the pilot is still going on, but this is just a snapshot of data collected between September of 2016 and July of 2017. So in that period of time, 61 patients were identified as being eligible. 50 of those consented to referrals, that's 82%, to Lighthouse Counseling. And then 76% of those were seen by a Lighthouse therapist. Now that touch point has improved over time as we learned that we needed to provide the therapists at the hospital more frequently than twice a week, partly because the length of stay was shortening for the patients. So now we have presence Monday through Friday as needed. And here's some basic characteristics and demographics. So patients reported being connected to a primary care provider. All of them said they had one and could list them. Over 3/4 were experiencing homelessness at the time of their index hospitalization. 3/4 were male, and about half were under or equal to 33 years old. And then the interactions, and Elisa really should be talking about this one, but just to be smoother, patient visits are at the Dominican Hospital or one of the skilled nursing facilities, as was just mentioned. The time from social work referral to our first visit was a metric we've been monitoring. It started off when we were there only 2 days a week to be an average of 3.2 days, and we got it down to less than 24 hours when we increased our presence to a daily Monday through Friday. Patients receive an average of 2 visits with the Janice therapist with a range of 1 to 6, depending on their interest and length of stay. Visits employ motivational interviewing, which many of you are familiar with as an evidence-based practice, to engage patients, explore their goals and interest in mental health and SUD treatment. And she supports the linkage to services upon discharge. And I don't mean just cuddly support, but literally does the pre-screening and gets the medication orders coordinated with social work and makes the intake appointment and so on and so forth, and transportation. So we also wanted to look in the medical record for the shared medical record in the county just to get a sense of recent acuity of mental health symptoms. And so this is these figures for outpatient county mental health. 32% during the pilot period had had an episode. 36% had had a jail mental health crisis team visit, and 24% had had a visit with our acute psychiatric care. That was a little bit beyond the pilot, maybe 18 months or so period of time. But these are pretty similar figures to a SAMHSA publication that looked at high utilizer groups, high utilizer groups and claims data. So that was interesting to note. It also gave us a sense of who else in the community we wanted to make sure that we collaborated with. Okay, and then patients' engagement. We wanted to see how many of our patients actually made it to SUD treatment. So for our medication-assisted treatment clinics, we had 30% had new episodes. Doesn't mean they were never known to the clinic before, but they opened new episodes during the pilot period. 40% had ongoing, they were already known to the clinic and had ongoing episodes. And 22% had an intake into our residential treatment facility and received medication-assisted treatment during that stay also. Several of those 22% had multiple visits to our residential treatment. In terms of engagement or connection with SUD treatment, we were looking for what's out there, what are other people doing that are doing transitions-like programs. And so we found that there was one publication about, this is the SAMHSA one, excuse me, one publication that looked at how many people had claims for outpatient SUD after leaving inpatient care in a hospital, and it's only about 17%. Now that's insurance folks, so we're getting a fairly good hit rate here, but there aren't a lot of published data yet on these kinds of programs. All right, so in terms of SGD outcomes, so how are people doing in their medical record when they're in treatment? And it looks like for those in residential and MAT, now these are small sample sizes, so these are probably pretty unstable figures, but just to give you a sense, at the time of discharge, 73% were meeting treatment goals according to ASIM severity dimensions. So that's good. And 94% at the MAT clinic at 30 days or more into their episode were also meeting treatment goals. Now, to compare that to something in the literature, in Boston Medical Center, they have a transitions program also. That is a little bit different than ours, but we wanted to see what's their connection rate. And it looks like when we compare ours with theirs, again, we have a small sample size and they have 53 folks who actually made connection and were still engaged in treatment in their methadone maintenance clinic, outpatient, after being discharged and transitioned, warm handoff to that clinic after an inpatient stay. So that's encouraging. We'll see if, as we get more numbers, if we stay there. And then in terms of outcomes, use of hospital services, so this is a popular metric in the literature and not probably very popular with hospitals, the 30-day intake, right? So within 30 days of their index visit, 32% of our folks visited the ED again, and 16% then were admitted. These are pretty similar to what we see in the literature, so we're right in there, we're not really better. And this is literature looking at folks that don't necessarily have transitions kinds of models. And then for mean number of all-cause ED episodes within 30 days, it looks like it's about 0.55 for folks in our cohort who did not receive any SUD or COD treatment, so they didn't come to Janus, and for 0.38 for those who did receive treatment. So it looks like it's moving in the right direction. For getting outpatient care, it seems to help that reutilization, but these are not statistically significant, at least not yet. Same thing here for inpatient hospitalization, same kind of pattern. And now, Elisa will tell you stories.
Okay, so I have a few stories, but I also want to talk a little bit about, not that, there we go, some of our successes, and kind of weave stories a little bit into these successes. So the successes, we've had strengthened collaboration across network of providers. That's been amazing. Both these ladies talked about Beacon Health Options, Central Coast Alliance, and then we're working on other coordinations as well. Informal rapid cycle quality improvement of patient care. Improved referral and follow-up workflows between hospital social work staff and Janus therapists. That's been a huge learning curve for myself and the social workers at Dominican, and it's really been a privilege to work with the social workers because they're so brilliant. They know what they're doing, and just to be part of their world when I'm not a medical expert is really quite a privilege. So being able to coordinate with them in such a way has been really neat. Shortened time from referral to first patient visit, 3.2 days to 24 hours. Lisa talked about that. So initially, we were just kind of doing an on-call thing. When there was a referral, then we'd send a therapist in. And then we decided we need to have a daily presence because maybe if a face is shown to the social workers, they will be reminded that they need to look through their caseload and see if they have somebody that qualifies for this. And so that has really helped increase our referrals as well as the time in which we've been able to see the patient. And as you know, engagement decreases from referral time to seeing a therapist. So when we're able to get right in there, the patient is still fairly excited and remembers signing a release. And so that's really helpful. So we've met with 50 referred patients, which is wonderful, and engaged 11 patients in new residential treatment episodes, which That's been where the major learning curve has come. A lot of these patients don't really qualify for intensive outpatient just based on the fact that 80% are homeless and a number of other disqualifying factors. So the fact that 11 people have made it into residential treatment has really been rewarding. Engaged 15 patients in new MAT episodes, and communication of a streamlined process for accessing rapid intake at MAT clinics. So that has been really, I think that's still a work in progress. What? Oh, that's still a work in progress. And our MAT staff at Janus has been so accommodating and has been willing to do intakes on days that are just not typically their days for intakes, and so they rally their staff in such a way that seems so smooth to us, and I know that they are just working hard to make things work for these patients, and it's really been a neat collaboration. Clarification of eligibility criteria for patients entering residential SUD treatment directly from the hospital to the SNF. So that's been, our clearances have needed to become more specific and thorough and things like that. So challenges and next steps. So rapid access to SUD treatment. That has been one of our biggest challenges, is there are acute mental health needs, there are acute medical needs, and that's a little bit further down. And the job of the hospital is to get people discharged quickly. And so often we don't have a bed available, so there's this lag time that comes into place. And so we've really become creative in ways to keep these people stable. There's hotel vouchers, we've used RCC, different creative methods to help stabilize these clients during the time that they have to wait to come into treatment. There have been some amazing cases where we've done door-to-door service, and that's been beautiful. Housing, like somebody said earlier, that's the elephant. I don't think I need to go into that. Medical and mental health complexity, I just talked about that. Coordination with existing and new initiatives. So we really hope to work further with some of the initiatives that you guys have talked about here and we'll continue to talk about for the rest of the day. I'm seeing I'm short on time, so I'll run through this quickly. Reluctance of hospitalists and ED physicians to start Suboxone in hospital, and I was just having a conversation with our nurse about this, and she really believes that it's really a lack of experience, not so much reluctance, and so we're really hoping to improve that and just get a bit more understanding of what this looks like. And stigma and lack of social support. So with our population, they just don't have social support. One of the things when they do come into residential treatment is they're able to gain that support. And we've really seen that when we connect them with the AA community and when we connect them with refuge recovery, things like that, they are gaining a social support network, and that's been really wonderful. So next steps. Increased Medi-Cal coverage for residential SUD treatment. That is coming our way, and we're really excited about that. Janus itself is preparing to have a 40 bed, yeah. So we're expanding, and so that will really help the lag time that comes into place between the patients coming from the hospital and then coming to Janus, because they'll have funding. Right now they don't have funding, and so we've done some work around with that, but it'll be really nice that they can just come straight into the hospital with funding automatically. Training in VI SPDAT, some of you know about that, and that's going to be wonderful. Licensing to provide incidental medical services in the SUD treatment, engagement and training of hospitalists and ED and MAT, part of the California Hub and Spoke MAT expansion initiative. I know many of you guys know about that. Proposal for phase 2 funding to expand eligibility and include a peer support specialist trained in RAP. RAP is Wellness Recovery Action Planning, and we really hope that, I'm hoping to get trained in that. We hope to have our peer navigator get trained in that so that we can really start discharge planning from the very beginning, which is exactly what these guys need. And so stories, I didn't really weave any stories into that, so I want to speak to one of the acute medical needs and kind of the learning curve that we went through. We had, in the very beginning, we had a patient who was interested in coming into residential treatment, and I was really just excited to get people into treatment and didn't know that there was a lot of precautions we probably needed to take because I'm a layman when it comes to medical things. So I was excited, I got this person in, and we get a call from the public health nurse that this person has Hep A. And our admissions team goes, why didn't you tell us? And I said, I had no idea. This wasn't told to me. So that's when we decided we need to get access to these people's histories and physicals. We need to have a much more thorough screening. There's different questions we need to be asking. And so that's really helped us streamline and smooth out our process. What was beautiful is we all worked together, and we were able to get this gentleman a hotel voucher for 2 weeks. And he showed up to treatment 2 weeks later, and I don't know how he's doing now, but he completed the program. He hasn't had any ED visits since the program, so it's really doing what we set out for it to do. And then another gentleman, this was actually just yesterday, I was walking through our DUI services, and I look at the people waiting in the room, and I see this very handsome, well-put-together gentleman, and he looks up at me and he says, hi. And I was like, hey. And he goes, don't you remember me? And I looked at him harder, and I went, oh my gosh. And he goes, yeah, you were in my hospital room. You got me into Janet's. And I was like, oh my gosh, this is amazing, and this is the gem. This is what we're working towards. And I said, how are you doing? What's happening? And he was signing up for DUI services so he could get his license back, and he got reconnected with his daughter, which they weren't unified at the time. And so that was a really sweet moment for me, and just to see that this is working, this is doing what we're hoping for it to do. So those are my two, I think, most rewarding stories, and just really outline the goal of what we're doing, and that we are doing it. So thank you. One more?
I neglected to say the piece that Don pointed out with our person who had their heart surgery. They were in the hospital at that time for, I think, 6 to 8 more weeks. And so at the time that this project started, people were in the hospital for 6 to 8 weeks, not getting any recovery or support. So that was really the sort of underlying reason for this project, and now things have shifted. I think for me the key for the success of this is that we're really doing short cycle rapid improvement. So the Plan, Do, Study, Act, PDSA, we're really using that concept, really trying to be nimble with what we learn and how we grow and change.